Welcome to Living Vividly, the podcast where health, wellness, and curiosity collide. I'm Jackie, the founder of Vivid Health and Wellness, your guide on this journey to living your happiest and healthiest life. I'll be joined by some amazing co-hosts who bring their expertise and energy to every conversation. First up, we've got Daphne, our unconventional yet totally brilliant registered dietitian who's never afraid to shake up your approach to food. Then there's Dr. Mary Beth Moss, a physical therapist with a special passion for helping dancers move better and live better, no matter what stage of life they're in. And of course, we can't forget our trusty producer, Dustin, who helps keep everything running smoothly behind the scenes. We'll be having informative and engaging conversations with health and wellness pros, plus everyday people who've got incredible stories of their own health journeys. Whether you're looking to fuel your body better, move with ease, or just learn how to thrive in this crazy world, we're here to help you do it, all while living vividly. So let's dive in. Welcome back to another episode of Living Vividly. Today we're joined by Dr. Melissa Thompson. She's a pelvic health physical therapist who's on a mission to educate and empower women to take control of their pelvic health. Through her work at Louisiana Pelvic Health, she helps women with issues like postpartum recovery, pelvic pain, incontinence, and more. Things that are often ignored, dismissed, or just accepted as normal, but they definitely aren't. Thank you so much for joining us today.
Yeah. Thank you for having me.
Thank you.
Tell us a little bit about what is pelvic health?
Yeah, tell us about the pelvic floor. Like, where does that, let's start there.
Yeah, that's a great place to start because we do find that most people have no idea what it is or probably in today's, modern healthcare, it's super dismissed. And then probably the number one issue is just awareness of what is it, who needs it, why would I need it, how's it going to help me? So the pelvic floor is a big powerhouse of muscles that is actually the floor of your core. So whole bunch of muscles that you have that connect from the front of your pelvis at the pubic bone to the back of your tailbone. So it functions as a big sling that goes from front to back and then from side to side connected from sits bone to sits bone. And so because of the location of these muscles, it's going to support a lot of our reproductive organs, and it's going to support our bladder, our bowel, our uterus, and also in men, the prostate. And so by nature of that being in kind of a private region, it's going to control peeing, pooping, intercourse, birth, and then also kind of zooming out into the support of your spine, your hips, your core, and ultimately pretty much every movement that you do. And so it's really just a part of your core that's often overlooked, and it's a whole series of muscles. It's not just one muscle, and they go from kind of outward and superficial to deep and really internal. And so they're all accessible via the vaginal opening or the rectal opening.
So
There are so many questions.
Where do I start?
Wait, the sits bone. I'm sitting on the floor right now. Is that literally like the two bones that are hitting the floor?
Yeah, if you want to see if
That's
you
cool.
can find your pelvic floor, if you've ever done a contraction or a Kegel and you feel your two sits bones coming together, that's your pelvic floor doing that.
Okay.
But relax. Don't sit with a Kegel the whole time.
Just go silent for a whole minute.
how do we know our pelvic floor is healthy or if it needs help?
So a healthy pelvic floor supports all of those things that I talked about. We want to be able to urinate every 2 to 4 hours without feeling strong urgencies or that we are having to go all the time or having pain when the bladder is full. A healthy pelvic floor is flexible for intercourse, meaning you shouldn't really feel burning or pain or aching upon any kind of like gynecological exam or insertion. If you have a healthy spine, your pelvic floor connects to that. Like tension in the pelvic floor or weakness can actually be a cause of tailbone and low back pain and sacroiliac joint pain. We see a lot of constipation as well. And so constipation can be affected, of course, from internally, like from what you eat, your lifestyle, your nervous system. But we call it, when the pelvic floor muscles are involved, it's outlet constipation. And so your pelvic floor is so tense and it's holding on and closing the base of the rectum. And the stool's not able to make its way completely out. And so those are kind of the big things that people are able to relate with of like why what would be like a warning sign that my pelvic floor is involved? The leakage, constipation. Back pain is hard to say because there's so many causes, right? So we really, really have to do a good evaluation for somebody with back pain and sciatica and tailbone pain. A lot of causes there, but the pelvic floor should be evaluated in those cases. And then like prolapse, pelvic pressure, sometimes I'll get reports of like a golf ball. I'm sitting on a golf ball, or, I'm doing a deadlift or a squat and I feel like things are falling or going down. And so we should be able to do strength training movements without feeling leakage or pressure or pain. We should be able to do those other functions, bladder, sexual function, and the bowel functions should be healthy. And then our back and spine, tailbone and hips.
I had no idea how involved it was. I thought it was just like a postpartum thing. Like I had a baby and now I pee on myself a little bit. I didn't realize that it wasn't just pregnancy related.
Yep. So I would say peeing on yourself after having a baby is easy to recognize. And it's definitely a pelvic floor symptom because the vaginal tissue was stretched. Maybe there was an injury or a tearing. And so that's a little bit easier to conceptualize and to relate with. But in reality, I have probably about 50% of my caseload throughout my career has been more like chronic pelvic pain, even pre-pregnancy with some kind of underlying history. So somebody with endometriosis, interstitial cystitis, or just like maybe they always leaned towards compensatory patterns and they have a lot of tension in their pelvic floor, really a lot of stiffness in their spine. All that's going to trickle down to being symptomatic with certain activities and movement, strength training, or intercourse. And so I work a lot holistically to let's figure out what's going on directly with the pelvic floor. But then I am a doctor of physical therapy primarily, so by background. And so I'm still looking at what joint is involved, what's actually causing the pelvic floor to behave the way it is. So it's a little bit of detective work in our field where we're looking directly at maybe that leakage or that pelvic pain with intercourse, but then we're constantly asking the question, why is it that way? Because if all we ever do is tunnel vision into that one muscle group, we're never going to be, independent with the treatment. Like we don't want somebody to have to keep coming forever and ever and ever and ever and dealing with the same problem. If we can clean up where the pipe is leaking and not just the puddle, then we can actually truly get a picture of what's going on and what's causing that problem.
How did you get into this?
Yeah, people ask me that all the time. So I would say a lot of us in physical therapy that want to go into something more specialty based probably deal with the issues we're treating. Mm-hmm. And so I have kind of that endometriosis presentation, chronic pelvic pain. I have a hypermobile body type. So I'll be like up and down with different pain depending on what I'm doing, and I have to manage it. That kind of led to me experiencing pelvic therapy for myself throughout different models and with different practices. And then I started going down the rabbit hole of getting specialized as well because it was hard for me to find practitioners I started with the traditional medical model and I had so much just trauma from being prescribed pills, being told everything's fine. And whenever you're dealing with something, one of the most disheartening answers after going to a medical visit is everything's fine, just relax, you have nothing to worry about. And it's like, well, why does it hurt?
It's like you're getting gaslit.
Yeah. And so I spent a long time, trying to find my way, especially when it came to fertility. And then I just basically said, I don't want women to deal with this. Like we need to create a team for them where they can have the referrals they need in the more holistic environment. And it doesn't have to be holistic like woo-woo-y, but just like if you really want to deal with all these things, here's a functional medicine option. Here's some labs you should be asking for. This is the lifestyle changes you need to make on top of the pelvic floor. And I mean, I don't give all that like, hey, I just met you. Here's all this stuff you need to do. But
it's a journey.
People just don't even know that those resources are there. And they think, oh, this one doctor is who I have to ask for everything for. But they're telling me nothing's wrong. So I guess I'll just live with it. And that's just not really acceptable.
Yeah, I feel like this is such a specialized thing that not just any general doctor can deep dive into your pelvic health.
Yes, exactly. And so if you think about like an OB-GYN, they're wonderful. We absolutely need them. They're doing a pelvic exam from a different perspective, right? Mm-hmm. They might be looking for the anatomy of the uterus, the health of the vaginal tissue to make sure there's no infection. They might be looking at pathologies that physical therapists that's out of my, scope to pick up some kind of abnormal cervical cells or something like that. When you're going in for labor and delivery, like they have their role there, but they're not doing a pelvic floor assessment. So a pelvic floor assessment is very specific. It's a muscle test. And that is where physical therapists are the experts in evaluating and treating muscles in relationship to the rest of the joints and how that matches with the presenting complaint.
If you don't think there's anything wrong and everything's normal, is there a way to know if that strength you're talking about is there? Like, is there like a test you can do, or is it just you only know if something goes wrong? You're like,
assessment?
Yes. So most of the time, the pelvic floor is what we call anticipatory type muscles. So think about your rotator cuff in the shoulder. We don't really hear about the rotator cuff until it hurts, right? Because those muscles are there to stabilize the ball in the socket. They're just kind of a low level active. They should be nice and healthy, but they shouldn't be overactive. So when we have weakness and dysfunction in the rest of the shoulder complex, rotator cuff kicks in, tries to overwork. Oops, I did something outside of my strength level. Maybe I got a little tear on the rotator cuff and now I'm in pain. Go down that world. The pelvic floor is kind of the same way. Most of us aren't thinking about it. We're not supposed to think about it so hard or to worry about it. But then when there is kind of one of those like yellow warning signs, we start going down of like, what is this? Oh, it's my pelvic floor. And so kind of all those factors of, bladder health, sexual health, bowel health, if those are all normal for you, likely there's nothing to worry about with the pelvic floor. The landscape is changing and there are more and more patients calling to say, I don't really think I have a problem, but I don't want to have a problem. So can you evaluate my pelvic floor? And so there are ways that we can do more of like a wellness assessment to find out if the pelvic floor is healthy with different movements, the way that we want it to move, and to proactively teach strategies so that you don't lead down the rabbit hole of dysfunction.
I'm going to ask you about some questions that would be pertinent to me in my profession. I deal with a lot of people that have constipation and just difficulty using the bathroom. And obviously there are a lot of food things that we can do. Obviously what you're putting into your digestive tract is going to affect the way that your digestive tract functions. But at what point would you say, what point should I be looking at to say, okay, I don't know that it's food necessarily as it is a structural issue that needs to be addressed?
I think anyone with constipation is a candidate for a pelvic floor assessment because there are manual therapy skills that we can do that they can learn on their own every time they want to stimulate a bowel movement. Mm-hmm. And we can make things move a little bit easier. We can teach some behavioral and positional things in the bathroom. And then I personally do a lot of myofascial work to the pelvic floor for constipation.
What does that mean?
Like internal pelvic floor release.
Okay.
Just like you would release your neck or your back, or like think of like a skilled myofascial type of therapy. We can do that to the pelvic floor. And I see really, really good results doing that if the patient, wants to go to the pelvic floor perspective. And then on the flip side, like if I see the patient first, I'm referring them to somebody like you because I'm telling them we have to attack it from two sides.
Right.
It can't be all myofascial work. Like there's never going to be a solution that's like, just do this one thing.
Right. Just one side.
Everything's going to be perfect forever and ever. And so I'm a big believer in like, let's start with what, you came for, but I want to educate you along the way that are you skipping breakfast and then you're loading up on, coffee throughout the day and then you're not having enough protein and that's its whole other
all the time
thing to
all
work
the time.
on.
All the time.
Yeah. Especially for women. I find women undereat.
I don't want to make this all about food, but that's where my heart is. I see so many people that have constipation. So I look at it from the food, from the dysbiosis, if that's an issue. But the third thing that I would need someone to help with, obviously, I'm not getting in there doing myofascial anything in their rectum. So that would be a good place for you to step in.
Yes, absolutely. And I know we haven't talked about, so my husband, Dr. Patrick, we work together now for a few years at the practice. And he's a fellow with, it's like an alphabet soup for orthopedic PTs. A FAOMT is what it's called. This is like a highly...
Say that one more time.
FAOMT, FAAOMPT.
Oh, goodness. Okay. Never mind. Sorry.
Yeah. So he is very skilled and has a lot of training with dry needling strategies with the nervous system and other myofascial techniques. And so he and I will co-treat for these constipation situations and for chronic pelvic pain. And we see really, really good results so it's that holistic theme of like, I'm doing the internal components and then he's doing really, really skilled components from the external perspective. And we see for constipation specifically, people will come back and say, I went every day. I don't know what y'all did, but I want to do it again.
Yeah.
That's incredible.
Yeah.
I didn't even know that was a thing.
It's so fun whenever somebody's like, not to make this all about constipation, but somebody's like having this, like, it's hard, it's something that no one wants to talk about, but whenever they tell you, and then all of a sudden they're like, oh my goodness, I'm not having that difficulty anymore. I'm not having that pain. It's, it has taken away that hard part of life that I don't want to tell anybody about,
Do kids suffer? Like if a kid is constipated, is it because of pelvic floor issues or is it normally food? Do y'all treat kids?
I personally have not done training for pediatrics. So my understanding from pediatric pelvic therapy, most of the times they go into pediatric therapy and then they niche even further into pediatric pelvic floor. And so a lot of the treatment looks a little bit different at that age range. Like we're not doing internal work for someone typically under 21, we wouldn't. And so the strategy becomes behavioral, play-based, more along those therapy lines. But yes, constipation in kids is kind of an up-and-coming thing people are talking about. And there's a whole world of pediatric pelvic therapy for that.
Getting back a little bit to pregnancy and just preparing for that, is this something that you would recommend someone start working with you to get their pelvic floor strengthened before getting pregnant? Would that be beneficial for them?
Yeah. So I mostly see patients in that situation when they're going through fertility things, or they might already know they have a history of something. So I also am trained as a fertility awareness practitioner through Lisa Hendrickson Jack. If y'all have read her book, The Fifth Vital Sign, it's all about the health of your menstrual cycle as a vital sign of like what's going on with your body and your health. And so I got trained in that to help my clients in this phase. And so I teach them how to chart their cycles, and let's look at what your cycle is doing. Let's correct what we can with the lifestyle. And And let's kind of understand what conversations need to be driven to maybe a doctor or someone ordering labs or something like that. So I teach my fertility clients the charting piece, the lifestyle piece, and then I'll also look at their pelvic floor and try to see where they need to start to address the preconception stage. And more research is coming out that, like, for example, in the situation of PCOS, we know that certain receptors are downregulated in vaginal tissue, and then that's going to affect the ability to hold urine in or to relax and contract. And so it's all connected is basically the story. We want to move away from this idea of, now I'm experiencing infertility, what should I do? Or now I'm postpartum and I've had all these injuries, what should I do? We want to move away from that sick care model to this proactive wellness care model. And I think physical therapy has made some strides in that, because now we are doctorates and we do have direct access in Louisiana. So we can be your primary care musculoskeletal doctor, so to speak. So we encourage people to come at all stages before there's problems, but also we are skilled to address the problems as well. But I see a lot of patients now that are more like, I just don't know what I don't know. Like, what can you teach me? What's my pelvic floor doing?
How does the pelvic floor change during pregnancy? Like from preconception to conception, and then as pregnancy goes through, obviously your body goes through a tremendous amount of changes, but what kind of changes happen with the pelvic floor throughout that process?
So first, during the first trimester, the uterus sits low. And then as the placenta forms and you move into the second trimester, it starts moving up into the abdomen. And all the way to the very late third trimester, it's up into the ribs.
Your uterus is...
So the whole...
What happens when you put a baby in there?
I didn't know it. I didn't know that moved. I knew like the other stuff moved.
Yes. And so what's under your ribs? Your diaphragm. And so the diaphragm gets squished and flattened, and then the ribs have to splay and flare. It happens so slowly that...
It's like your teeth moving, kind of.
Yeah, you don't feel it. It's just now we have an inefficient movement of the rib cage, an inefficient muscular activation of the diaphragm because it's stretched out. We have ab muscles that are now stretched out, so they're not in the same length tension relationship for a proper contraction. And the same thing's happening from the bottom. It's like everything's just slowly lengthening and stretching. And so that's why during pregnancy it's common to feel pelvic pressure, weakness, a disconnect from the area of being able to have that mind-body connection of the pelvic floor. And then for your spine, as that belly is pulling you forward, your spine is moving more into what we call like a lordotic curve. It's kind of an overgeneralization. It depends on how people compensate. But we see a lot of like L5, S1 back pain. Sometimes that's where the sciatic pain can come from. It's from constantly just pressing on those joints. And so with the pelvic therapy, I teach my patients how to just reactivate all those muscles with a little bit more mind-body focus. Let's do that from like a basic standpoint, and then let's put that into exercise at the gym to really strengthen and, elevate. And that all of that can get you comfortable during the pregnancy and can put your pelvis in good alignment for labor and birth.
And so after delivery, when you don't obviously have the baby there, how long does it take, or how does, like, I'm assuming it's not just like things just pop back into normal from where they were pre-pregnancy. So what does that pelvic floor look like after pregnancy or after delivery?
Yeah, so it depends on how the delivery went. So if you have a standard vaginal birth with no tearing, pretty smooth, you're going to be dealing with weakness. Probably not pain, but most likely weakness because the vaginal tissue stretches 33% of its capacity in just a normal, healthy vaginal birth. And so same concept, stretched out muscles, they don't know how to contract. And so you've got to focus on rehabbing the strength from that standpoint. If you add on a perineal tear or an internal tear or a tailbone injury, now we're talking about a muscle tear, kind of like that rotator cuff tear, hamstring tear. And so that rehab looks different for the different situation. And then if we have a C-section, and I get asked the question a lot, why am I having leakage if I had a C-section?
We talked about that.
That is actually because you had a surgery through several layers of muscle, connective tissue, fat, and the pelvic floor. And so instead of that big stretch to the pelvic floor, you're actually having a little bit of kind of a rearrangement of how it was sutured down from the top. And so I see more just holding in and tension from a post C-section, which can also cause the bladder to leak. Because if we think about how these pressure systems really work from the bladder, the intra-abdominal cavity, and the pelvic floor, it's all a big physics equation. And if pressure up top of the bladder exceeds pressure down at the pelvic floor, i.e. the strength, you're going to get a little bit of dribble when you jump, laugh, or sneeze. And so all these factors play a role into the recovery. In a perfect world, if I'm working with a prenatal client, I will design them some basic things to start doing from 3 weeks postpartum, which is probably a little like shocking to everyone listening because everyone is probably familiar with that 6-week visit. But what we're finding is most moms are resting from birth to 6 weeks. They're going to get that pelvic exam. From the physician standpoint, they're cleared medically. They go back to CrossFit. They go jump on the trampoline. They go for a 3-mile run, and then they're disappointed because something happened. They leaked. They felt like they had prolapse symptoms, but it's because there was no baseline rehab to build to that level. So it's not your fault. And a lot of doctors will tell these moms, well, that's normal. You had a baby. These are common symptoms. Give it a few months.
Yeah, I would say common is not normal. So common means that, it happens to a lot of people. That doesn't necessarily mean that it's a normal thing, though.
Yes. And so pelvic therapists are over here going, no, you need to do some diaphragmatic breathing. We need to learn how to engage the pelvic floor. We need to be figuring out if that scar tissue needs a little bit of work. We need to look at your glutes, and we need to do this all in a safe way when, the lochia, the bleeding after birth, like if that's still going on, we need to do this in a safe way where we can progress you so you're not just doing nothing. And then when you get to that 6 week, then we can get to that middle level where now we're challenging the system, but we're not going for a marathon yet because 6 weeks is still rather early.
Yeah. Right.
So I don't think immediately going to jumping and 3-mile running at 6 weeks is going to work for everybody.
Do you think that every woman that delivers a baby needs pelvic floor therapy?
Yes. And in fact, in Europe, it's done that way.
Really?
Yeah. Like the last time when we spoke to Dr. Elena Clark, and I said every mom needs the chiropractic care during pregnancy and after. I feel like this should be also required because we're just not looking at everything.
Postpartum, there's so much happening. I mean, hormonally, physically, you're not sleeping, you're, barely eating because you have another human to take care of that you didn't have before, So there's just so much going on that your pelvic floor is the last thing that's on your mind.
Yes. And so that's why I hope to see you during pregnancy, and at the last month or so, we can really talk about postpartum and plan for that. Because now that I have a baby, I know I wasn't thinking about myself, and I wasn't going to go make an appointment and at the last minute of not really understanding. And yeah, I think that if it was pushed more because everybody knows that they have to go to the 6-week follow-up. And, everybody has time to do that and looks forward to that. And so, pelvic therapists are really trying hard to make this, even if it's a one-time check, it's worth it to get peace of mind and to not feel like these things are happening, but the doctor is saying, well, give it 3 to 6 months. If you're still dealing with that, then I'll give you a referral. I hear that so many times, and it confuses moms because in all 50 states, there's some level of direct access and you don't need a referral. And so moms get confused. Well, the doctor said I didn't need it.
Right.
So I'm really embarrassed about it. I don't really want to have to do it. Well, they said I didn't need it, but I am dealing with these things. They usually end up researching on their own and then kind of going on their own.
I think you always think like, well, maybe if I just ignore it and not do anything, it might just go away. Like I might just be able to sneeze and not pee on myself.
Yeah. And, sometimes there are certain ailments that can be fine. But typically with the pelvic floor, if the muscle is weak, it's going to be weak unless it's strengthened.
It doesn't just get better on its own.
There's some level of things kind of readjusting in the early postpartum weeks, and some level of diastasis is coming back together on its own, and some level of prolapse getting better. But imagine if you went and addressed it earlier, you would be that much more ahead of yourself. And then there's all these things you can do to make it worse. And so just having the education and the armor to know, oh, I shouldn't hold my breath when I'm having a bowel movement. That actually can make the prolapse worse. Like a lot of people just don't know these things, and we shouldn't expect them to know these things.
Can you explain to us what exactly prolapse is? So different types of prolapse, uterine prolapse, vaginal prolapse. Like what is prolapse?
Yes. So whenever I talked earlier about the pelvic floor supporting the pelvic organs, this is where prolapse comes in. There should be good strength in the pelvic floor so that all those organs are lifted and supported. Bladder, bowel, uterus, prostate. When there's let's say a weaker pelvic floor, let's say it sits lower with less just natural muscle tension, like baseline tension, you can have that uterus fall a little bit down the vaginal opening. You can have the bladder fall into the vaginal tissue. You can have the rectum fall. And so someone might notice when they go to the bathroom some tissue coming out. That's the most obvious sign. The other signs are like pressure. Pelvic pressure, something's down in there. It can be weakness. It can be tension, cramming and pushing everything. It can be that those uterosacral ligaments from pregnancy are now stretched, and they are so ligaments, once they're stretched, they don't tighten back up. Ligaments are different. They behave differently than muscles. Muscles can be stretched and then can be contracted back again. Ligaments do not do that. So after your pelvis widens, the uterosacral ligaments stretch, and all those tailbone and sacral ligaments stretch. That's why postpartum, some things with the postpartum wider hips are going to kind of stay that way. But it's that much more important to strengthen, because that's your only factor now that can tighten everything back up, is having really, really good strength in the pelvic floor, the glutes, the core.
So prolapse is the protrusion of one of those organs. So if somebody has surgery to fix their prolapse, let's talk about that, because if somebody has uterine prolapse and they have surgery, that's not addressing the pelvic floor. Is there a way to fix a prolapse with the pelvic floor where surgery is not necessary?
Yes, we see that all the time. And actually what we see, and it also matches in the research, the degree of prolapse does not correlate with the degree of symptoms. And so what we care about is symptoms. I don't want to be having surgery if I don't even have symptoms. But sometimes you get these doctors that just call it out to you. Oh, there's a grade 2 prolapse. And they're, what's that? Oh, your bladder's falling a little bit. Oh my gosh, what should I do about that? And then, we're putting harm into the patient's mind. And I would say maybe that patient doesn't really need to focus that much on their prolapse if it's not bothering them. Maybe they need some educational things to not make it worse. And maybe the doctor is like, well, it's really coming out, and they really see it. On the flip side, I'll see a patient that has a very minor prolapse, but they're like, every time I have a bowel movement, I feel pressure. I have to splint, which is a technique where you can push it back in order to evacuate the bowels. After intercourse, it feels worse. But then I evaluate it and I don't see a big like coming out or protrusion. And so this leads the question of then how do we evaluate who needs surgery? If surgeons are looking at grade 1, 2, 3, 4, but we're looking at function, symptoms, and lifestyle. And so I've seen time and time again where I've helped a patient rehab and they've canceled the surgery. And then on the flip side, I've seen post-op with the same symptoms. And so are the symptoms really coming from the prolapse, or is it more complicated than that?
So I guess this goes to everybody's individual and needs to be assessed individually. We can't just blanketly say, I mean, that goes for just about everything, but we can't blanketly say that if you have prolapse, then you need surgery, or that pelvic floor therapy can always help the prolapse and your symptoms will go away. I mean, it kind of needs to be assessed.
Correct.
Individually.
And yes. We advocate for physical therapy first. There's lots and lots of studies to support the overuse of healthcare dollars for imaging, surgery, medications. And if they had just gone to PT first, they would have reduced all of that so much. Even for something like low back pain, which I think a lot of people have had low back pain. And we hear time and time again, well, I can't go to physical therapy. I've got to go to my primary care doctor first, who isn't trained in the musculoskeletal diagnosis and management of low back pain. So they're going to say, how much pain are you in? What prescription do you want, or topical cream? And then if it doesn't get better with this, let's refer you to an orthopedic. So then you do that. You go to an orthopedic. They say, let's get you scheduled for an MRI, because that's the only way we can see all the structures. So you get on the schedule for the MRI, comes back. There's an incidental finding, because every single one of us in here probably has something we didn't know we had in our spine.
Right.
And then they say your options are physical therapy or surgery or an injection. So you end up at physical therapy anyways, but now you've waited and waited and waited. And so I don't know how I started this tangent, but that's the same kind of analogy with prolapse and bladder. And I've seen a lot of patients that said, my doctor said the only thing was a hysterectomy.
Yeah.
That, well, you're welcome to try pelvic therapy, but I think that's probably not going to work, and we'll just go ahead and schedule the surgery. And again, we're just placing so much doubt in the patient's mind, where they're having to be their own doctor, so to speak, and advocate for themselves and really tease out, what do I think? Do I think I need surgery, or should I keep looking for solutions and see if maybe just that's that doctor's skill,
right?
Like what's really right.
And I feel like once a doctor tells you that your only option is surgery, like we've talked about this so many times, they'll just believe that. And once that seed is planted, they lose hope for all the other therapies that might work and prevent that surgery.
Yeah. And it makes it hard when they end up in my office, because they already don't believe, right, that this is going to work.
That's half the battle.
I'm like, okay, so this is my challenge, is I just want this patient to know that there's hope. And then if they stick to the plan, they do the therapy, they do the home program, they're just like, I can't believe I feel better. Just like, holy crap, like, wrapping your mind around the fact that it could just
it was like magic.
Muscles.
Yeah.
So I'm still stuck on the whole, is it a problem? Does it cause something? So what's the issue if it doesn't bother them? Like, what's the, let's fix it if it doesn't.
You mean for prolapse specifically?
That's the $1 million question.
So that is a big,
that's the same
thing.
question of, why do we need surgery for a herniated disc? You didn't even know you had one.
Right. Okay. I mean, that makes sense. Like, is it the result of a different problem, or if you fix it up front and it never bothers you, then...
Yeah, I would say for the person that has an undiagnosed prolapse that they don't even know they have postpartum, they're asymptomatic, I would say they are probably just walking around with a little bit of prolapse, and they're probably fine. Of course, there's things that I would love to teach that person about bearing down and weightlifting and not making it worse, but I'm not going to say, well, you've got to go see a surgeon to deal with that.
What's the risk of a prolapse? Like, that's what I don't know.
Medically speaking, things are just not in the right place.
Okay.
And so let's say you're trying to get pregnant again. You can have some malpositioning of the uterus that can make the anatomical travel of the egg and the sperm and implantation difficult. You can have a more increased infections like bladder, UTIs, because you can't release the urine as easily. And so the longer the urine is retained, the more likely it can grow into a culture. But if it's just kind of there with movement and it's not bothering the patient and they know how to evacuate and they're meeting the standards for all of these healthy markers of bladder bowel function, they're probably not at huge risk for medical issues.
Yeah. Well, I mean, I have a friend who has a herniated disc and it doesn't bother her at all, but it's Jade.
Yeah.
She's talked about it on here with us. Whenever she had an x-ray or an MRI, her doctor was like, oh my gosh, do you know about this thing in your spine? And it doesn't bother her.
Yeah. And it's actually very daunting to be told that and to see it. And so...
But it sounds like the same thing. Like, she's doing all the things to make sure it doesn't get worse and bother her.
Yeah.
You would be doing all the same things to make sure it doesn't get worse and bother them.
Yeah.
And what we know about bulging discs is that a lot of people in their 20s, 30s, 40s have a bulging disc or have had an injury of a bulging disc. The body will resorb the affected tissue, meaning it's not bulging anymore. But where does the pain come from then is the question. The pain comes from the nervous system response to that injury. And so a lot of times that's what we're treating. We're not necessarily left with this lingering bulging disc. We're left with motor patterns that have never been corrected. So we're continuing to bother it over and over again. And the brain knows how to respond to that injury because it's done it before. It responds with pain. And so I see a lot of patients that say, 10 years ago, I had an injury. It was a bulging disc. So they lead with conversation of like fear-based. So I don't do X, Y, and Z because I know that I have that bulging disc.
They want to protect it. They're trying to protect themselves.
So now we've created patterns where we can't disassociate the pelvis from the hips. The pelvic floor is going to compensate. Like everything's just in fight or flight protection mode. And so as soon as they go to do an exercise like that, they're like, oh my gosh, that hurt. I knew I couldn't do this. And now we're in this positive feedback loop to the nervous system.
Self-fulfilling prophecy. Yeah. So I'd like to talk about Kegels because we can't talk about the pelvic floor without Kegels coming up, right?
Of course.
Tell me about Kegels from your perspective, because that's always whenever I was growing up, like just do your Kegels and that like solves all of your anything pelvic floor. We didn't call it that then, but like any kind of sexual health related stuff, just do your Kegels.
Yeah. So there's this guy, I've already forgotten his name, but his last name is Kegel. And he's the one that found that the pelvic floor muscles can contract. And there is a subset of people with pelvic floor weakness that are appropriate to contract the muscles, and that will improve bladder function and even sexual function like orgasm. And that will kind of tighten things up. And I think years and years ago, this was revolutionary, right? Because it's the first time the pelvic floor has been looked at, studied, scientifically. And I think it's the easy way out to just, your doctor tells you to do your Kegels, or I can't tell you the number of pregnant women that tell me, well, I'm just doing my Kegels, so I don't need pelvic therapy. And in reality, we know that now that we've done so much more research, we have so many more pelvic therapists out there treating over the past 10 years or more. We know that a Kegel program can make people worse, is not functional, doesn't translate to strength training, and it's just a passive way to address the pelvic floor. And so if you think about what's important in the postpartum phase, it's lifting a car seat with one arm and walking across the house. It's, bending over to the bassinet or the crib. It's squatting down to get something off the floor. Kegels are not going to be the treatment for you. If you can Kegel all day, but can you do all those combined maneuvers with a load of 15 pounds because you have the weight of the car seat and the weight of the baby? Mm-hmm. And so we're thinking about it more from this full body lens. And then on the flip side, like pain with sex, most of the time there's tension or tightness somewhere. If we tighten a tight muscle, we are just continuing that pattern and actually can increase the pain. And so sometimes I'll get patients with pain with sex that have done a whole bunch of Kegel therapies and they're just not working. And I evaluate the pelvic floor and I say, I think I need to teach you a pelvic floor relaxation strategy on top of the internal myofascial work, set them right in one visit. I mean, it's not that they only need one visit, but they're finally like, oh, wow, I didn't know that. I thought Kegels was the blanket,
Right.
And this is why, we haven't talked about this yet, but Patrick and I are out of the network with our clinic because what you'll find with insurance is that they are promoting the lay on the table Kegel therapies. That's what they'll reimburse. And so a lot of patients that have really wanted to use their insurance do that first, and then I failed pelvic therapy, or I can't believe I even spent my time doing these biofeedback machines while my therapist left the room for 20 minutes and I was just playing a game with my vagina trying to contract it. And we just know that those are a more tunneled in treatment that can be appropriate, but it's not a blanket appropriate treatment for everybody.
Can Kegels help with hemorrhoids?
Maybe.
I don't know.
Hemorrhoids, I find more pelvic floor tension and more bearing down as the causes or the contributing factors. And if you don't know what bearing down is, so if we go back to that physics conversation, think about Valsalva maneuvers, breath holding, doing things like that. We don't realize how often we actually do that. Mm-hmm. And I see this in lifters because some strategies with lifting that are actually intentional are Valsalving in order to get rigidity in the spine, but then they're not training the pelvic floor to handle that amount of pressure. Anytime your pelvic floor can't handle the pressure, it goes to the path of least resistance, the pelvic floor, or the diastasis, or hernia is kind of the consequence, like the result of
the weak spot of the balloon.
Mm-hmm.
Mm-hmm. Yeah. So how does the pelvic floor change throughout, I'm asking specifically about women, throughout a woman's life cycle? So we've got the pregnancy part, the prenatal, the pregnancy, and then postpartum, but even after that, aging. And I'm really, menopause.
So perimenopausal. I love working with the perimenopausal as well. So very interesting changes. So if you think about what is driving the perimenopause, it is the decline in local ovarian hormone production, estrogen, testosterone, progesterone. There's an average of 10 years that it takes to actually hit menopause. People are most symptomatic during those 10 years because that's when you're feeling the effects of the roller coaster, right? And how that affects pelvic floor tissue, we need testosterone for blood flow. We need estrogen for that suppleness and that pink color in the vaginal tissue. We need estrogen to hold the sphincter, the muscle, shut. And so if we start having a weakness or like a change to the muscle because of the hormone input, now we're presenting with pelvic floor symptoms. And so perimenopause, menopause tends to be another time where patients would be seeking out pelvic therapy. And a lot of that is going to be treated kind of the same way with the evaluation lens, but then I'm asking them about their lifestyle, if they're interested in an estrogen cream, what they're doing to lubricate the tissue, who they're working with to do that kind of workup. It's really important to replenish now some of that hormone and moisture, just depending on their situation. Like, if someone has cancer, they're going to need to work with their oncologist on replenishing with hormone creams because that may not be the best route for them. I have a lot of products that I like that are non-hormonal that people can get over the counter. And then if they want something prescriptive or hormonal, they would find either an OB-GYN that deals with some of those things or a functional medicine doctor that can do that full picture workup.
But the symptoms would be similar with just bladder dysfunction or bowel dysfunction. I mean, all the symptoms would be about the same. Just coming at a different stage of life.
Yes. And if you think about postpartum, there's a rapid decline in hormones. And if you're breastfeeding, your estrogen is suppressed. So they say postpartum is like a mini menopause presentation as well. And so they feel the same sorts of symptoms. So what I will hear often is sex isn't the same. It doesn't feel comfortable. I'm leaking. I feel pressure. And they're 45, 50, 55, but they still relate it to childbirth. But it might just be now that all of these perimenopause and menopause changes are...
Just the hormonal changes are the driver of it at this point.
Yeah.
Just like all pregnant women should be seeing a pelvic therapist. I feel like as we age, like you go to your OB for these things, and so many women just aren't getting the answers that they need.
Coming from someone who is menopausal, the last, I'd say probably 6 years have been such a roller coaster ride hormonally. Just all the changes that have been, and I know a lot about hormones, I mean, this is what I do, but it has been a wild, wild ride.
The body is wild, and it's really fun to see all these different practitioners and see how they all fit together like a puzzle to treat people holistically.
And that's what Patrick and I are big believers that, we're all a team. And I think as people start advocating for more, it's nice to have a team of different perspective professionals that can just be your people that you go and see, almost like to keep healthy. Again, with that different philosophy, then it's really bad. Now I need to go figure out what's going on.
I think every type of practitioner looks at health and wellness just from a little bit of a different lens. So when you can get all of those perspectives, like if you were standing in a spotlight and you had the spotlights coming from all different ways, then you can really shine.
See the whole thing.
Yeah.
Yeah.
Really
beautiful.
And it's nice. You don't realize how fast an hour goes. I see my patients for an hour. And when I can focus on just their pelvic floor perspective, and then I can send them to a massage therapist that can do a really good job, better than me, on doing an hour-long massage. Like, I don't want to be trying to cut corners and getting them all these different things and squeeze it into an hour. And so, that's also the other benefit is like, go to the people that are just like super experts in that one thing and like really dial in with that.
Yeah. Having a network of providers is really important, which is why we kind of started this podcast, so that we could shine a light on all the different providers and what they do in their role.
Yeah. Bridge the gap between the people that need this work and the people that can help them. Yeah. But speaking of an hour, we're at our time. So we have to ask you one final question. So what does living vividly mean to you?
I guess that really just means like being aware of your body and being an advocate for yourself and really enjoying your life and being comfortable in your own skin and kind of just knowing as much as you can and learning and going off in tangents when you answer questions.
I love it.
Yeah, living your best life and not feeling like you just didn't know that, so it passed you up.
Well, thank you so much for coming on. This has been great.
Yeah.
Yeah, thank you for having me.
Very interesting. Thank you.